good morning if you are in California, good evening if you are like us organizers in Europe, and probably good night if you are watching this from Australia. I see in the chat box that we have people from all over the world again, just like in the first day. Please be welcome to use the chat box for the second part today, as you did very well in the first part also 2 days ago. In order to use the chat box, you may have to register as a YouTube or as a Google account user, and then it will also count you. So the number that you see of other participants are those that have actively registered for this chat box. You can at any time go backwards in time and review what has been stored there by clicking on the main window. Then you should see a red bar, and it should be right now on the upper right. That means you are in live contact with us. But if you need to take a break, or if you want to watch this at any time later, we will keep the recording until the end of next month here, end of June. Then you just click on the window and push the red bar to where you want to go back. But you will also notice that the chat comments will also be stored there until next month. So if you have any private gossiping on the chat box, we will enjoy it too. So let us know if you are from outside of Europe. And I hand over to Anna Maria Vitali from Fisicamente Formazione in Italy, my co-host for this session.
Thank you, Robert. Thank you for the invitation. It's an honor to be part of this team and introduce Professor Nathaly Gaudreault from Canada. She's a physiotherapist and a full professor at the School of Rehabilitation, Faculty of Medicine and Health Sciences at University of Sherbrooke. And she will talk about the challenge of palpation. So, Nathaly, are you ready?
I am ready. So thank you very much for this nice introduction, Anna Maria and Robert. And thanks to this organization for giving me this great opportunity to talk about the challenges of palpation. And I would like to dedicate this presentation to those of you who cannot work with their hands at the moment and probably miss it probably as much as me. So I will start my presentations. You can go to the next slide, please. So my primary intention is a little bit to share my internal struggles with assessment of musculoskeletal tissues with hands, with palpation, as a clinician, as a researcher, but also as a teacher, because I teach young students to use their hands. So this is my primary intention. And my second intention is to share my tiny, small contribution to the production of knowledge on manual assessment. We can move on to the next slide. So as many of you know, many healthcare professionals use their hand to evaluate, to diagnose, and to treat their patient. And I'm thinking about medical doctors, nurses, physical therapists, osteopaths, and even exercise therapists uses their hand. And certainly, palpation is a valuable tool. It allows us to find landmarks on the body, to evaluate position of body segments. And also we can evaluate mobility of organs, mobility of tissues, and spinal mobility with palpation. We can evaluate the size, stiffness, or roughness of tissues. And also, most importantly, we can detect red flags for very serious illness with our hands. So these are very, very powerful tools. And we can, palpation is used to do some procedures with precision. I'm thinking about injection. If you want to inject the long head of the biceps tendon, you have to be precise for your medication to go in the right spot. And also, it helps to monitor the effect of treatments that we are giving to our patient. And this last point, to me, is the one that you see that I'm putting question marks, because how valuable, how precise, how accurate our hands is to evaluate the effect of our treatment. And this is challenges that I will talk about, in the following slides. So we can move to the next slide. If I start with my internal struggles, these go as far back as when I was a physiotherapy student, because when I've learned to assess, let's say, spinal mobility, I will talk about bone as an example, because bone are obvious structures. They are easy to find, they are easy to palpate. And so we were learning that, when you do, let's say, a postero-anterior mobilization of one vertebrae, you have to find the first resistance and then the second resistance. And it looks a little bit like the curve that you see on the right side of the screen. And I was telling myself, it's weird, because, I feel a resistance, as soon as I just put my hand on the vertebra. And at that point, I had to use a 3 categories scale to assess what I was feeling. And it was either normal, hypomobile, or hypermobile. And then the treatment options were, okay, if it's hypomobile, I have to increase the mobility. And if it's hypermobile, I have to stabilize. And so far, it was not, too complicated, but things got more worsened as I was a practicing physiotherapist, and I was into continuing education classes, and I had to use this 3 category scale now to subdivide. The hypomobility became hypomobility minus, hypomobility plus, and then hypermobile became hypermobile minus, and then hypermobile plus. And I was already struggling with my 3 category scale, and then they asked me to subdivide these categories. And the worst thing was that I felt that I was the only one who couldn't, feel these things. And it was quite, scary and disappointing, because I said, oh my God, if I don't assess well, I will not be able to treat well, I will not be efficient. And, I was fighting with myself. And when I started some osteopathy training, it was even worse, because now we had to do things with organs. And so I said, okay, I'm not good. And that's why I gave up on osteopathy. One of the main reason, because I felt that I was not good at it. And we can move to the next slide. At that point, it was 10 years that I was a physio, and I started a master degree training. And I said, what if it wasn't just me the problem? What does the science say about palpation of musculoskeletal tissues? And I started to read the literature, and I said, okay, maybe it was not just me. A part of it, but not all of it. So we can move to the next slide. When I started to read about sensory motor coupling, although we're using palpation for centuries, the process of action, sensation, and perception is not yet very well understood. And if you look at the schematic representation on the right side, that involves so many processes. If you start with the touch, you have to use your hand your brain as to recruit muscle to touch something. So it starts there. If you go fast, if you go slow, this will have an impact on how your fingers will touch the tissue. And then this tissue, what is the properties of the tissue? Is it hard? Is it soft? And there is a very huge variability of on the same body and on various tissues. And then this information has to go to the spinal cord and up to the brain. And here it goes to the sensory motor cortex. And although now very nice research said that it's not all going to the sensory motor cortex, some of this information goes to other places of the brain to act on the autonomous nervous system. So you can see that, anything can happen, in these steps. And this complexity makes it really hard to establish reliability, validity, accuracy for palpation, namely for palpation of the soft tissues. So if we move on to the next slide, these are very interesting research from people that are doing research in haptic sciences. These are mainly engineers, and they work on robots to help surgery, to make surgical procedures. And it's really fun because what they do is they put EMG electrodes on the muscle, and then in a very controlled environment, you have on the center of the left illustration, they do that with sort of a silicone pieces in which they put a little something that you have to touch and monitor your feeling about that little ball which is inside the silicone, which is instrumented. There is this little ball can provide information about the forces, the intensity, the direction of the forces when you arrive on the little silicone pieces. And what these people show that in a very controlled environment, I'm not talking a body which is a changing environment. Clinician variability is present, like in the force applied, in the velocity, maybe less for the direction of the force when we arrive to palpate. But this is to say that if these parameters, or varies, that can explain the difference in the evaluator reliability when assessing palpation of a body structure. And what is interesting is that joint stiffness, they monitor with EMG, is that joint stiffness plays a very important role in the haptic information. So whether you palpate with a very relaxed hand or a hand which is stressed, that will have an effect. So the field of research is very, very interesting. Then if we move on to the next slide, at one point in my career, I got interested in epistemology. To me, it was a very big word when I started to do research. And I said, oh my God, it's a good thing that I don't have to do epistemology during my postgraduate courses. Probably I got more mature as a person and as a researcher. And now this field is very passionate because epistemology is the field that studies the construction of knowledge. And you notice that, again, even though, as I said, palpation has been used for centuries, it is a new field. And we know from science that the older the field, like physics, the more rigorous the criteria for scientific validity are. And manual therapy and palpation is young in the history, like young in science. It's only 150 years of history. So when people are skeptic about what we're doing in manual therapy, I said, "Oh, come on, guys, give us a break. Like we're still young, we're still learning." So this is why maybe the science about palpation, is growing like more in the last decades with technology, and we start to have very good research to rely on, but it's still young in the history. And also the knowledge is very difficult to construct due to several factors. The first one is the absence of normal reference values, or there are only very, very, very few. So it's hard to say, okay, if I palpate a fascia, soft tissue, what is normal? Is it because I feel this is stiff that I'm not normal, or am I normally stiff? So these are questions that we have to ask ourselves. So this adds to the complexity of the sense of touch. And the last point is that we do science based on theories in manual therapy that have been accepted but lack some validation. And I'll, give you a very, very simple example on the next slide. When this is, a classic stress strain curve that most of you probably know. And what it does is that you have your toe region, which is the bottom of the curve. And then as you put more stress or more force, more load on the tissue, you see that the curve increases. And the toe region is the displacement for low level of force. And the famous R1 is for orthopedic manual therapists, but also when I talk to my osteopathic friends, they talk to me, oh yes, you go until the first barrier of resistance. So it is another R1. And I said, you see that R1 occurs and you have to feel with your hands this inclination of the curve. So I got skeptical. And when you look at the research, and this is it is a sort of a basic theory in manual therapy. I teach this theory, even though in my head I say, student, I'm teaching this theory, but I'm not quite sure about that theory, but still. This is the theory, and some studies have shown that even after training with visual feedback, students and even experienced clinicians couldn't separate the sensation of the toe portion of the curve from the curvilinear portion of the curve. So the famous onset of R1, and that comforted me a little bit because at least I couldn't feel that R1, but I was not the only one. So I was comforted with this. And if you look, the 3 examples at the bottom of the screen, this is for joint play movement, but I would be very curious to see if that occur with some soft tissue. And you see that for the tibiofemoral joint play, the resistance start, the slope right at the beginning. And for the glenohumeral joint play, it's the same thing. It's as soon as you put a force, you have a displacement, and it's the same thing for the radiocarpal joints. So to me, it is not surprising. Like the resistance occurs immediately after the force is applied. To me, it follows Newton's third law, so action-reaction. So when I say my last point in the epistemology slide, questioning the theory, this is what I'm talking about. And this is what we should do as clinicians, sometimes question the theory, because when we look at the literature and we look at the reference in the list of reference, you have a reference that is cited into the text, and then you look at this reference, and often those references do not present original data. They state someone who said that, and this is important to look at original data. But again, we're still in a vicious circle because there's not much original data. And one point is because we have to do research to have original data. And as many of you know, getting grants for research in manual therapy, it's not easy. We have to fight against aging, against cancer, against these very serious illness. And us poor manual therapists, we're not a priority. But this is another story, and we'll talk about that in another presentation. So if we move to the next slide, questioning the theory. When we use our hands, what is the reliability, accuracy of palpation? And whether you're a physiotherapist, an osteopath, chiropractor, massage therapist, whatever, we're not good. And this is what the literature says about reliability. And there are multiple studies that investigated inter-examiner reliability and accuracy. And when you look at literature review and meta-analysis, the conclusion is that it ranges from poor to good. So a lot poor and a very few good. And this range is explained, but it depends on what structure is being evaluated, the level of experience of the therapist, and again the quality of the studies, the population, and there is heterogeneity in the methods. But one thing that often that is consensual is that experience is a factor. The more experienced you are, the more reliable intra and inter-reliable you are. So, but experience might not be the only thing. So if we move on to the next slide, and you'll see why I'm saying that experience might not be the only thing to explain the variability. So I'll move on to the second part of my presentation, where I will present you my little contribution to the palpation science. And as a physiotherapy teacher, we knew, my colleagues and I, that our students were not very good at locating musculoskeletal structures with their hands. We knew that. And even in our senior student, I said, okay, what should we do? And it's really hard to make them be very, very serious about learning anatomy. And I keep telling them, listen, anatomy, it's like learning the letters when you want to learn to read. If you don't know your letters, you will not understand the text that you are reading. And you have to understand your body to be able to palpate and to conceptualize that structure in your brain, especially when you work on a body, it's in 3D. And learning anatomy in books or in these very nice 3D software, it's nothing like learning from the real. And I'm thinking about cadavers, and I'm using ultrasound imaging more now because you have to have a very good 3D representation to know where your structures are. And I said to myself, if you have difficulty to locate structures, how can you be good at integrating what are the sensations that you feel when you touch that structure? If you think that you are touching a bone, but you're on a ligament, and then you say, okay, or vice versa, you think that you're on a ligament, but you're on a bone, and then you say, I want to do a test to try to loosen this ligament a little bit to have more mobility into a suspension system, and you're on a bone, you're not very well started, I would say it. So we did this study on our first year physiotherapy student at the end of the first year, when they have all the classes about the theoretical and practical classes about the musculoskeletal anatomy, and they say, okay, we'll see if they can locate 4 musculoskeletal structures. And I did that with one of my fellow orthopedic surgeon. He was interested about his resident as well. So if we move on to the next slide, I will show you a little bit there. I will talk briefly about the studies. So we had orthopedic surgery residents, first year physiotherapy student and 4th year physiotherapy student. And what they were asked was to locate with palpation the long head of the biceps, and then the tibialis posterior tendon, the tibiofemoral joint line, and then the AC joint line with their hands. And we had 2 independent palpation stations with human models. These were physiotherapy students who volunteered. And then the student had their standardized instruction. Listen, you have to find these structures. You cannot do that. You can do this, and blah, 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 blah. And then if we move on to the next slide, what they had to do next, once they found the structure, we used the method proposed by Rowe and collaborators. They had to put a truncated needle on the surface of the structure. The needle was used as a landmark. It was not within the skin, it was over the skin, and we taped it. And like for the joint space, we asked them, you have to imagine that you see the joint space, and you put the needle within the space, parallel to the bone. And for the tendon, it was the same thing. For the tendons, you have to imagine the tendon, and you have to put the needle as if it would be in the middle of the tendon. And we took ultrasound imaging of these of the needle placement. And then we move on to the next slide. I will show you our criteria. So the criteria were established by a team of experts in musculoskeletal imaging and orthopedic surgeon. I was there, and a rheumatologist, and who else? A radiologist. And we teamed up based on our different needs regarding palpation, because between the profession, the disciplines, our needs was different. And after focus group and looking at about 80 images of the structures, we established these criteria. So for the AC joint space, these are the images that are on the top row. If you look at the first one on the left, you have the clavicle and then the acromion. And then the red circle was where the needle was the hyperechoic needle, and we draw a line. And if that line fell within the space, the palpation was deemed as a success. And you have on the left side of the screen for the AC joint space an example of a failure. You see that there is the needle, the yellow line, and it fell on the acromia. So for us, it was a failure. And underneath, you have an example for the tendon, the posterior tibialis tendon. You have on the right side a successful palpation. You have the malleoli, and then you see the posterior tibial tendon on top of the malleoli, and the needle was on top. We draw the line, and if the line was touching the margin, it was okay. If it was touching the tendon, we considered it as a success. And seeing many images, we had a very huge variability of the possibilities, and at one point these possibilities saturated. So we knew, what was considered good for us and what was considered a failure. So based on these criteria, then 2 physiotherapists that use ultrasound imaging and that were trained in ultrasound imaging were asked to independently evaluate all the palpation and to make a judgment call as whether it is failed or successful palpation. So I'll show you the result on the next slide. This is our participants. So we have orthopedic residents. We had 10 of them, 22 first-year physiotherapists, and we had 17 fourth-year physiotherapists. What is interesting here is that the fourth year we did the first year a couple of years ago. So the fourth year are the fourth year of this year. So there is a star just close to the 17. It's because of the coronavirus. I couldn't finish my stats with these students because my machine is at the lab and I cannot still get into the lab. So this is why I'm not finished yet with the analysis of the fourth year student. And please hear, the goal was not to say that physiotherapy students were better than orthopedic surgeons. That was not the goal. They don't have the same training. So it's not my message here. So if we move on to the next slide, which is, we did first an inter-evaluator agreement on the use of the criteria. Are the 2 physiotherapists agreed with their call of success or failure? And we were quite happy because we can see that for the AC joint, we have a kappa of 0.86, tibiofemoral joint line, it was 79, and perfect agreement for the tendons. So we were happy about that. And when we considered all the structures, it was 0.92. And then what about the success and failure rate? We will see it on the next slide. Here you have in the column on the left side the structures, and then you have the ortho resident score, the PT first year and the PT fourth year. And if we look at PT, that's why I'm interested in, we can see that the joint lines, only 31% were successful at locating the tibiofemoral joint line, and the AC joint was 18.2, and the biceps, long head of the bicep was only 4.5 success. And then the posterior, tibialis posterior tendon, sorry, it was not joint line, it's tendon there, it's 63 success. And interestingly, those that, I only have 17 here, as I said, it's not 22, they were better at the fourth year, except for the posterior tibialis tendon. So what happened? Like, did they forget about that tendon, along their training? Did it disappear? And I was quite, discouraged because few of the students palpated it on the lateral malleolus. I said, oh my God, as professor, what did we do wrong? But this can be explained, hopefully. So the message here is that we have to find ways to do better with teaching palpation skills. And I think there are literature that demonstrate that introducing ultrasound imaging right at the beginning of the training, because with ultrasound doing some no anatomy, it's wonderful because you have a very good 3D representation. If your conception of a structure let's say the bicep tendons is too medial, then you look with ultrasound and you can say right away, you can give a feedback, listen, you're way too medial. So you see, you have to be lateral, and then it's, oh, okay, yes, I missed it with something else. And so now it is, we liked it because at least, and we know on which structure we should put more emphasis in our teaching. So if we move on to the next slide. It was interesting because other studies look at palpation skills, and in the osteopathic literature, there are very, very nice studies. And this group, probably you know about that test when you put a coin underneath sheets of paper, and you have to find the coins and to see with 50 sheets or 100 sheets of paper or 500 or 400 sheets of paper, can you still locate the point which is underneath. And what they show, if you look at the little graphic on the bottom of the screen, you see like the I don't know the word in English for that color, but the top curve, you can see that this is the number of correct finding of the coin. So with 50 sheets of paper, you have a lot of correct location of the coin, but as the thickness of the papers increases, you see that the number of correct palpation decreases. And it was interesting as a test. It's really, it doesn't cost much, and I think it's a good way to try to discriminate those students that might need to practice more than others. And there was what was interesting was that there was a great variability in the palpation skills at the beginning of the training of the term. So when I said that experience might explain good reliability in palpation, but it was not all, I think, and I truly believe that some person has it. It's in themselves. They're good with their hands, they're good at feelings, and I think it's innate for some therapists. And unfortunately, I think I was not I was not part of these therapists. So that was very interesting. And what is interesting in that study is that participants that exhibit less developed palpatory skills at the beginning of the term improve, and those that exhibit more developed palpatory skills at the beginning of the term decline. So it means that you still need to practice even if you're good. So if we move on to the next slide, this is interesting because this group did a reliability of this, I call that the coin under papers assessment tool to assess the palpation skill of the students. So I think it's a very a neat example to demonstrate how tools that can help us to improve, to teach this skill. And as I said, ultrasound imaging is a valuable tool, but the validity for measuring fascia has not been established, and there's still a lot of work for us to able to do it, to assess palpation of the fascia. So if we move on to the next slide, I'll talk to you about our work here. What we wanted to know in this work was, when we teach this spinal mobility, is there a difference between the intensity of the force applied by physiotherapy student versus senior physiotherapist, practicing physiotherapist? And if we move on to the next slide, what we did in this study, on the left side, you see that there was a treatment table that was on force plates. The floor was, there was force plate embedded into the floor. So the models were lying prone on the table, and when the therapist was doing the movement, we could record the force, the intensity of the force, because of the force plate that were on the floor. And if we move to the right of the screen, we asked students and physiotherapists to assess the second lumbar vertebra and the fourth lumbar vertebra. On the left graph, you see in gray, this is the student, and in black, you have the physiotherapist. And we can see with our eyes that the physiotherapists experienced physiotherapists have a tendency to put higher force. Our student And these were senior physiotherapy students. They're scared. No, they're scared of force when they evaluate and I think this is normal. They don't feel confident yet, but you can say that, okay, if the effect of the treatment is dose dependent, maybe they're not quite efficient when they start their practice. But hopefully, I think that force intensity is not the only parameter that can play a role in the efficacy of a treatment. There are other mechanisms. So I am comforted about that. And we have the same profile for the fourth lumbar vertebrae. So following that, if we move on to the next slide, another student, she's a colleague actually. She's an experienced manual therapist teacher with many years of clinical practice physiotherapy. She's a teacher in our program, and she wanted to do a master degree. And she said, about assessment of the lumbar vertebrae, I realized that when I have trainings and I put my hands on their hands, they feel that it helps to find the right sensation. And she wanted to evaluate whether if we teach the normal way, the usual way, how to perform these movements. So on the left side, you see that we teach that the usual way by the teacher, have a model, and he said, okay, to do a posterior-anterior vertebral motion, you put your hands like this, and then you do this, and then the students experience on themselves, and the professor are just going from table to table to look at the position of the model of the hands, but that's it. And Annie, my colleague, said, okay, this is the usual way, and on the left, we'll do that, plus we will have a kinesthetic feedback with the hands of the teacher. And she wanted to know if the force of the student that had the kinesthetic feedback were closer to the force that a professor would apply for a given grade of mobilization. And if we move on to the next slide, I think this was our measurement tool. So she put a sensor on her PC form, and then she measured the force, and then the sensor was on the vertebrae, and then she did her technique, and then the student was doing the technique, and we wanted to know if those that had the kinesthetic feedback, there was less difference between per force, because there's no reference value about the force. What is, in Newton, the force that we should apply for a grade 4 mobilization? There is a huge variability again. So we use her as the gold standard. And we did that on a real model, and we did that on a mannequin that you see on the left side to see if on a control environment, we would see a difference. But unfortunately, those that had the usual training were not better than those who had the kinesthetic feedback. But those who had the kinesthetic feedback, they had, 100% satisfaction rate. And they said, do that. I mean, it doesn't cost anything. So just implement that the teachers put their hands. Like, we will not be better at, putting the right intensity of force, but we feel better. So to me, it was a good result. And that was a very interesting study anyway. And if we move on to the next slide. Okay, I'm talking about bone and tendons, and I'm, in the fascia research summit, and I guess that all of you are saying, okay, when is she gonna talk about the fascia? So here it is, and I put it at the last because my coming out as a fascia researcher is quite recent. So I have not done much research about the fascia yet, but it's coming. And when we look at those who have investigated the reliability, I found this article that evaluate the inter-rater reliability of the palpation test when doing facial manipulation, which is the STECO method. When they assess the patient, they have a movement test, a movement verification test, and they have a palpation verification test. And based on these results, you do your clinical reasoning, and then you build your treatment plan. And they wanted to know They did that with the movement the reliability of the movement verification test. But here I'm presenting the palpation verification test. And we can see that the inter-rater reliability is quite good. You know, it ranged from it is around 0.9 with a 17, with a 75% agreement. And it was strange because their intra-rater reliability is a little bit, it's good, but a little bit less. And usually the intra-rater reliability is better. So it is interesting to see that in that case, it was it did not happen, but we can see that it's good. And to me, these are crucial studies if we want to be better at putting evidence in what we do in manual therapy. So if we move on to the next slide. So here it is a study that we started to study the C-section scar. And one of my students, she wanted to know about the osteopathic treatment. What is the effect of an osteopathic treatment? At first, she wanted to do the global osteopathic treatment on the C-section. What is the effect of the treatment on different outcomes? And I said, you know, I would be more comfortable too, because osteopathy treatment, the global osteopathy treatment, is sort of a black box. And I understand why it is a black box, because every patient is different and the dysfunction that you find is different. So you have to modify your treatment according to your findings on the patient. And I said, well, you know, move back. And to me, as a physio and as a biomechanist, I'd like to talk about forces. And I said, why don't we just start with, if we put, you know, compression and sharing force on the scar, what does it do? And then, you know, if we find something, maybe one day we can assess your global osteopathic treatment. But for now, I would be more comfortable to start with, if I put sharing force on the scar, on a C-section scar, what are the effects on viscoelastic properties measured with the myoton, on touch sensitivity measured with the von Frey filament, and pressure discomfort measured with a pressure algometer. And I won't talk about the results because she deserves to talk about her result herself. She's still working on the analysis, and it's not, you know, doesn't belong to me to present these results, and probably at the next fascia research she will be there but I can tell you that it's very, very interesting, because it is the first study that we will be able to characterize what it does on the tissue. And another student who just came into my lab, if we move on to the next slide. So I'm coming to the end of my presentation. She liked that study and she said, oh, I would like to work on the C-section scar as well. And I said, okay. When the other student came to me and she said, I asked her, okay, when you're going to do your scar treatment, how will you quantify the dose of your treatment? Because maybe if a C-section scar has you see modification in the viscoelastic property of the scar, can it be because with one person you put more strain or stress versus another person? And she said, yes, but you know, in clinical practice, I feel the resistance and I will work in that resistance. Okay, but maybe your resistance will be different than mine when I do the same thing on the same C-section scar. And with that new student, we said, okay, we built this from my manual therapy project. We just recycle the mannequin, and then you see the mannequin on the bottom left. We have a silicone skin on the mannequin, but underneath the silicone, we put a sensor that will be able to record this sensor. It was underneath the skin, and then when she press on the skin, she has to tell, okay, this is the resistance. But if she was not pushing on the sensor, it was set in a way that it was providing a resistance. So she had to press and say, okay, I feel the resistance. But when she was not on the sensor, it meant that there was no resistance, because she had to push harder to meet that resistance. And if you see on the graph, these are raw data because we're starting this project. The blue line is the real resistance, and the red line, she did 10 trials, and you see that she started and said, okay, this is the resistance. And then trial number 2, this is the resistance. And at trial number 10, which is at the end of the graph, this is you see that she increased the resistance that she perceived at each trial. So it means that she was not even close to the real resistance. She was always going away from the real resistance. But for her, it was, okay, here it is, and here it is. But she didn't have any visual feedback. She was just relying on her hands. And then I said, okay, you practice. And when you will have a perfect score, so on the right side, you see that the red line, which is her saying, here is the resistance, here is the resistance. After 10 trials, she's very close to the blue line. And again, don't look at the units because these are raw data in microvolt. These haven't yet been processed, but this is acceptable. Like, I don't plan her to be perfect, but with my colleague engineer, we managed that, we have some flexibility. But it means that with practice, she got really good at sensing where the resistance was on that model. And I said, okay, when you're going to be good on a model, then we're going to switch to a human. And then if you move to the next slide, we build these gloves where we have a sensor on the thumb. It is, we built it with an old pair of socks. The socks were clean. These are instrumented socks that one of my colleagues uses in his research. These are intelligent socks that can monitor the center of pressure and all kind of things. So we had an old pair of socks, and I said, oh, I want to recycle the sensor. So and it's flexible. It's a really nice sensor, and we saw it on the thumb of the glove. So we know about the force that you apply on a C-section scar. So that's great, because what we will do, I agree that she will treat the scar according to what she felt. Now I know that she's good on a model. I said, okay, go on a human. I know that I feel better to let you go with what you feel on your treatment, but we will record these forces, and we will look at the effect of these forces afterwards. And so to treat her C-section scar, so she will use this glove, and we will be able to know about the effect of the force. My other student is using it too, but now with this second project, I think we will refine our method a little bit, and we use the Mayoton. So maybe some of you know about the Mayoton. It's a little device, and it produces an acceleration graph, and you can extract viscoelastic parameters. And again, I don't want to scoop, but we were skeptical. We didn't know if we could differentiate scar tissue from normal tissue. And we have very interesting results. So I'm not talking about these because they're not published yet. But Robert, if you're curious, because I think you work on the scar, and if you don't talk to anybody about these results, I will tell you about these results. So now if we move on to the next slide, you will see that it's fun because this student, these again are raw data. I just want to show you what we do. So on the left side, it's very, very small, but I will give you the numbers. And again, it's microvolt. It's not, the units doesn't mean anything. But I asked her to put the glove and work on it was not on a C-section scar. We had, a student that had a very big scar on her thigh because of a surgery, and we practiced on that scar. And I said, okay, practice with the glove. And here the intensity ranged between 40 and 65. And then this was done with visual feedback. And then I took off the feedback and then said, okay, try it without the feedback. And you see on the right, the range of the force that she applied were bigger. It ranged, I think, from 40 to 100. So I said, you see, you're not, the dose is different. And all we did, we just take the feedback away and see, now you are variable. So I said, practice. And when you're going to have consistency on the force you apply, then we'll move on to the project. And if we move on to the next slide, we can see that with practice. Again, this is with the feedback. You have the force between 40 and 65. And on the right side, it looks as if they were less variable, but it's because it has been rescaled, because you see that there are big peaks at the end, and what the machine does is that when you have big peaks, it rescales the data. But when we look at the numbers, she is between 40 and 65. So she's basically the same as when she has the visual feedback to guide her. So now I see that, you know, she's more consistent in the intensity of the force that she will apply, because I told her, I'm not stupid. I will not ask you to treat the scar with the same amount of force for every patient, because I know that for some patient it might not be enough. If the stiffness is, if the scar is loose, if you have a very tight scar, you have to put more force to induce a mechanical stress on the tissue and on the extracellular matrix. And I know that you have to adjust yourself, but I will feel more comfortable if you are more consistent about what you feel. And she's, you know, it's fun, because for these clinicians, these are experienced clinicians, and to put yourself into that sort of vulnerability is something. And I find that they are very courageous, and I'm very privileged to work with these people. So if we move on to the next slide, I'm almost done. Now this is the last research, and I'm very happy because this study is now accepted for publication. We tested the Myopron Pro. This is not about fascia, but it's about myofascial trigger points. So there's a little bit of fascia in that. And as we can say, trigger points, it's not only muscle. More research demonstrate that the fascia might be involved. So what we did, our question was, can the myoton discriminate a trigger point from a non-trigger point on the same muscle? We used the infraspinatus, and we had very good, it could discriminate. We had significant difference between the viscoelastic parameters of the trigger point versus the non-trigger point. And we had very, very good intra and inter-evaluator reliability, as well as test-retest reliability. So for those who are treating myofascial trigger point, to be able to put numbers on the effect of your treatments, I think that the myoton might work well. More research is needed to support that, like to support the construct validity, but we were quite happy with this. So if we move on to the next slide. To conclude, palpation is a very valuable skill to master and to teach, and it is valuable to treat and to assess and to diagnose. But we need to add more quantitative measure about what we feel, to be able to assess the efficacy or the effect of a treatment with palpation. Just saying that I feel that, I did that, and now I feel that, and this is better. I think if we want to have more credibility with what we do, I think we need to find tools to be able to evaluate that. It is important to know the underlying theory of what we are doing, because, as I said, the problem of not feeling might not be you. Maybe it's the concept that you are measuring or treating that, is not very valid. And again, practice helps. You should not stop when you get it once, but when you don't miss it anymore. And that's what I'm telling to my students. And to close this presentation, I will go with this very nice sentence if we move on to the last slide. So we try it out in practice, and then we see if it works in theory. So that's what I do for my wonderful living. So thanks to all of you.
Thank you, Nathaly. Very interesting presentation. I can see many comments. And first of all, compliments, because you are doing something that might help people in improving their ability, their skill, and that's a good indication for the manual therapist. So, so what do you suggest practically from now to the students that want to improve their skill in manual therapy?
As a teacher, I can say that they don't practice enough, especially first-year students. They have these wonderful time to practice, and often, and they have a teacher, on the spot that can help them, and they don't use that time, and they don't practice. And I understand, when I was a first year, I was very busy with things like party, and practicing my skill was not my priority. But as I think there are very nice ways now tools to, even for experienced clinician to keep going practicing that skills, and that's what I would practice.
Yeah. So I had the feeling that you were looking for quantified forces. So the aspect that might be probably now more investigated should be the sensitivity aspect. So how our haptic system is involved. So how the brain perceives the forces. So that's more complicated. What's your idea about it?
Yes, it's getting more complicated. And, as a biomechanist, I was very biomechanically oriented. And then I started to read about these researcher who was working with the sense of touch and the way touch act on the autonomous system. Yeah. And can decrease the stiffness of the tissue. And for that part, I don't have the answer. I need to read more and more, and to be able to even make a more integrated portrait of what we are doing, like the mechanical aspect and the autonomic system aspect of the touch. But this is fun. I will keep us busy for years.
So waiting for the next. So thank you very much for staying with us. And I don't know, Robert, if you have any question.
I have a million questions, but we do that later. And I look forward to your publications. And for time reasons, we need to go on to the next speaker. And we have a 2-minute break before we continue.
Oh, sorry.
So get up and stretch a little. So maybe we start in 3 minutes.
Okay, so thanks for...
And stay in the room, because it will be your colleague. Thank you so much, Nathaly.
Hi, everybody.
This one.